Doctors, we are live. You can start the session.
Okay, namaste everybody. Good evening everybody, respected senior teachers, colleagues and friends. I welcome you all for part 2 of Safety First webinar by Maharashtra Ophthalmological Society. Yesterday we had real brainstorming discussion and good inputs from the experts in this field, how to avoid TAS and post-operative endophthalmitis. In fact, we have divided this webinar into 2 parts for the sole reason that it's a very big subject to discuss only in 2 sessions. So first part was cleaning of the instruments, and now today we are mainly going to focus on operation theater and patient related issues. So for the benefit of those who had not joined yesterday, we would like to tell them that we have galaxy of world-renowned faculty, and I request Dr. Anagha to introduce faculty again for those who were not there yesterday, for the benefit of those viewers.
Thank you so much, Dr. Santosh. A very warm welcome to all the panelists as well as to all our viewers. Yesterday, we have had an excellent response and a great interaction with all of the esteemed panelists, and we would like to welcome them again today. We will have with us the president of our All India Ophthalmological Society, Dr. Lalit Verma, sir. He's also the director of Vitreoretinal Services for Center for Sight. Professor Namrata Sharma madam will be joining very soon. She is a dynamic secretary of the AIOS, as well as a professor of ophthalmology, cataract and cornea refractive surgery services at AIMS. We have with us Dr. Professor Mahipal Sajdev, sir, our immediate past president AIOS and the chairman and medical director of the Center for Sight group of eye hospitals, and always been a true inspiration to all of us. Professor T.P. Lahane sir would be joining us very soon. He is a professor, Regional Institute of Ophthalmology, GMC and Sir J.J. Group of Hospitals, a founder and chairman Raghunath Netralaya Eye Care and Research Institute, and the coordinator for Preventable Blindness Mission of Maharashtra. We would like to welcome Dr. Jeevan Titiyal sir. Thank you so much, sir, for joining. He is the chief of RP Center Ophthalmic Sciences, AIMS, New Delhi, and an excellent surgeon, always been a guiding light for all of us. I'd like to welcome Dr. R.D. Ravindran, sir. He's the chairman, director, quality, Arvind Eye Care System. And with his years of experience and expertise, he's going to guide us through and give us pearls of wisdom. Thank you, all of you, sir.
And we also have world-renowned ocular microbiologist, Dr. Savitri Sharma, who is the director emeritus of Laboratory Services at L.V. Prasad Eye Institute network of hospitals, and she has established ocular microbiology services at Arvind Eye Hospital way back in 1986, and since 91 she is working at L.V. Prasad Eye Institute, and institute has named chair of ocular microbiology in recognition of her services. We also have a brilliant surgeon, Dr. Haripriya, who is chief intraocular lens and cataract services at Arvind Eye Hospital, Chennai. We have Dr. M.S. Ravindra from Bangalore, who is the president of Bangalore Ophthalmologists Association. He has a vast experience of 41 years in the field of ophthalmology, a thorough academician, and he's chairman and medical director of Karthik Netralaya. We have Dr. Nirmal Frederick, my good friend. He is a principal assessor of NABH, and he's a incoming president of Tamil Nadu Ophthalmologists Association, and he's a managing director of Nirmal's Eye Hospitals. We have Dr. Deepak Megur, again a brilliant surgeon who has a YouTube channel, and he's from Bidar, Karnataka, Megur Eye Hospitals. We have our own young dynamic surgeon, Saurav Patwardhan, who is a medical director at Nandadeep Eye Hospital, Sangli. So we have a faculty galaxy of faculties. We have 3 Padma Shri awardees with us, and I am sure today's session is also going to be very interesting and very fruitful. And before we start our session, I think I request Dr. Anagha to share the results of survey which we had conducted prior to this webinar. Yesterday we had somewhere around 437 to 450 responses, and today we have more responses. So now she will share the results. Dr. Anagha, please.
Thank you so much, Dr. Santosh. I'd like to tell everyone that yes, now we have almost 475 responses. I'll be sharing the screen now so that we can just briefly go over it. I hope it's visible.
Yes, it is visible.
Yes. So this was a form that we had circulated in order to understand what is the kind of practice patterns of sterilization and cleaning protocols among us all ophthalmologists. So these 475 responses till today afternoon, as you can see, almost 70% of them are private practitioners, and they are almost around multiple setups are few, at 11% are institutions with single ophthalmology. Regarding the question of changing the keratome side port blades in the operation theaters, almost 70% of them were changing after every case, around 17% after 2 cases, and there were still a few who would change it probably only at the end of OT. So regarding changing of tips and sleeves, yesterday the discussion that we had, recommendation from all unanimously was to change for every case. And it's nice to see that almost 45.3% are changing after every case, but still 25.1% are changing only at the end of OT. So I think a very important take-home message that we had yesterday. Also regarding changing of the bimanual IA coaxial Simcoes for every case, like we discussed yesterday, the consensus was to change for every case, which is being done, as we can see, 54.7%, but 23.8% are still changing only at the end of OT. So again, an important take-home message. Regarding type of autoclaves, we had a great amount of discussion yesterday, where it was almost decided, and it was almost recommended that Class B autoclaves are absolutely important because it has the vacuum and the pre-vacuum stages also for complete air removal. When we can see here, almost 30% are using Class B, but 51.2% are still using only the vertical steam autoclave. So this could be an important take-home message. Using of flash autoclaves also discussed. There were varied opinions as to whether it is allowed or not, or whether it is recommended or not. 86.3% are not using, but 13.7% are still using. This is basically the immediate used sterilization. Regarding the indicators, it was decided yesterday that what is recommended is the Class 1 indicator on the outer part of the drum and the Class 5 or 6 indicators in each packages. As we can see here, 31% and 11% are using the Class 1 and 5 and Class 1 and 6. So this is also an important take-home message. Regarding cleaning of the phaco handpiece and tips, although 69.3% are using distilled water, 16.2% RO water, there are still some people who are using tap water, and RL also being used in 12.2%. So it's very important to use, as we had discussed, RO water or distilled water only. Regarding cleaning sharps and cannulas after every OT session, it was recommended that no betadine should be used, which is being used in around 20.2% of patients. 37.3% are using just the tap water, which also is now important. Non-enzymatic liquids, again, it was recommended that most of us should not be using the enzymatic or the non-enzymatic cleaners. Regarding drying of instruments, 51.4% are using blow dry and 22.3% the air pump. Ultrasonic cleaners was recommended to be used, but as we can see here, almost 48.4% are not using the ultrasonic cleaners, but they themselves, the cleaning and the drying of the bathtub has to be done very diligently. Regarding the choice of irrigating fluids, BSS is being used in almost 60% of by doctors. We had recommended yesterday that there is no need to autoclave irrigating fluids or viscoelastics because that changes the pH of the material. And we can see here there are around 9.5% who are still autoclaving it. Regarding the ETO of the phaco handpiece and tips, which some ophthalmologists are using to increase the longevity, however, that can be harmful to the environment. Around 18.7% are still using it. Using of intracameral moxifloxacin, because of the fear of TAS, there are almost 45% of people who are not using it, but that has been a recommendation in order to reduce the incidence of endophthalmitis, which is definitely a more serious problem compared to TAS. regarding which type of intracameral moxifloxacin, most of us are using prefilled intracameral, and if it is being used from the eye drops, as you can see, 23% are using directly and only 13.7% are diluting it. So this was the result from the survey. And I'd like to invite Dr. Lalit Verma, sir, to give his valuable thoughts before we go ahead with our questions.
Thank you, Naga. And I once again congratulate Maharashtra Film Society for taking this lead, because as I told yesterday also, this gave us at AIOS also the impetus to, keep working hard in this direction. This webinar is not a usual webinar. It's a different kind of webinar because there's no lecture baji here, but primarily panel discussions to arrive at some, they're all very relevant questions which have been circulated. And believe me, as Anaga showed in her 18 slides, the consensus generally does not emerge. And I was just overhearing, some conversation before the session started between RDR and MSR regarding whether we should have separate guidelines for smaller setups or bigger setups. So I don't personally think that it should be there, because primarily, although MSR, because even though most people may be doing 3 to 4 cases, but patient safety is always of paramount importance, and it disturbs the, psyche or the name of the institution also. And you see, what I would be looking from this 2 webinars, Santosh and Naga, is that we take this forward and arrive at some consensus, and maybe if need be, we convene a physical meeting just so that we arrive at a recommendatory kind of guidelines from AIOS side, so that ultimately, you see, patient care is of most important. Our patient should benefit. And secondly, a point which I highlighted yesterday also, that it pinches when doctors are held responsible for no fault of theirs, resulting in TARS or even endophthalmitis. Majority of the time, it is flaw in the irrigating fluids or anything which goes inside that's to be blamed. And as Naga had said, yesterday, what was discussed primarily was phaco tubings. And in fact, believe me, Naga, I also went back and saw YouTube today also. And I would recommend that everybody watches this, YouTube today and tomorrow's both sessions, and they become wiser. And today, as was said, OT related and patient related factors will be considered. And I'm sure that everybody would become wiser. And AIS would take this forward, Anaga and Santosh, and we would be looking forward to answers from all the genius people who are here, all the heads of institution, right from Arvind to, Maharashtra people, to Center for Sight, to Nirmal. So RP Center, everybody is here. And if they can't do it, nobody else can do it. You see, that is the, take home for me, that believe me, these wise people will help us, will help MOS, will help AIS also to draw some guidelines. And I am definitely looking forward after, these 2 days are over, to have a definite written guidelines, both on AIS website, and MOS in any case will do it, so that they are recommendatory to all the members of AIS. Thank you very much, and all the very best. And I'm sure this will go a long way, not only to prevent, because this episode has precipitated, this kind of event, but I'm sure this will, be a ongoing process. Thanks, Naga and Santosh.
Thank you, sir. Thanks a lot.
Thank you so much, sir. Thank you. So, thanking everyone for their presence here. We'll move on with our questions. And the first question is based on the operating room cleaning protocols. So the operating room is the heart of any eye institute. And definitely that is almost like the temple, and it needs the maximum attention. So we would like to first know what is the ideal way to clean an OT. Dr. Nirmal Frederick, sir, are you there? Dr. Nirmal, sir?
I think
okay. Dr.
Nirmal is there.
He's there.
He's there. Lane sir is not there.
I can't see his video on. Dr. Lane sir is joined.
Lane sir is not there.
Yeah. Okay. Dr. R.D. Ravindran, sir, can you please throw some light on it? What would be the ideal way to clean the OTI? Because I can't see Dr. Nirmal sir also is.
He's there. I'll just call him.
Okay. So you're muted. Can you please unmute, sir? Yes.
At the end of the surgical session, we clean all the surgical tables, the trolleys, all the equipment, everything, whatever is there, using the benzalkonium solution. We use a brand called Microl F, which is basically used for cleaning at a certain dilution. I'm not sure about the dilution, what we use, but it is diluted and used for cleaning all the trolleys, the table, chairs, everything. The same thing is also used for cleaning the floor. So, and once in a week, we also wash, because we have a kind of a marble floor in many of our hospitals. Wherever we have the artificial, the synthetic flooring, there we don't use them. Otherwise, that washing is also done, and the tiles, everything is also cleaned once a week. So that's basically what we do. So probably Dr. Ravindra can add to that. So
yeah, Dr. M.S. Ravindra, sir. What is recommended? Is there any evidence-based recommendation as to what chemical should be used and in what concentration?
I think.
Yes, sir.
Am I audible?
Yes, you are audible.
Okay. What is more important in environment, the surfaces, is not sterility. We are not looking for it to become sterile. We want it to be, they are disinfected. When the number of bacteria, spores, fungi, whatever it is, are decreased in amount. This can be kept by various ways. The cleaning protocols are there. It's a very long lecture. Cleaning protocol before we start the surgery, during surgery. So ideally, it should be cleaned after every surgery, but it's not practical in any situation. We have a protocol of cleaning at end of every 1 hour. 9 o'clock, 10 o'clock, 11 o'clock, we stop the OT for some time, and the floor only is clean, not the walls. At the end of the day, it's again cleaned. There are 3 kinds of protocols on every day, and weekly protocols are different, wherein we intensely clean the ceiling, the walls, and the floor. As Dr. Ravindran said, the surfaces should be compatible for cleaning. I mean, they should not be shedding particles. Only criteria is there are surfaces which shed particles. There are surfaces which don't shed particles, like epoxy and the vitrified tiles, the polyurethane paint. These are the ones which don't shed particles, and they should be seamless. There should not be any joints there. If there is a crevice there, imagine there is a crevice, you swab it with water, the water seeps into the crevice, surface may dry, the crevice will not dry. So that will be harboring bacteria which will multiply. It's a seamless surface. The corner should be coved surface so that there is no sharp angle. Sharp angle, you can't clean it. These are various ideas. Ideally, it's not good to use any disinfectant, okay, for the walls. Like we use Savlon, we use Bacillocid, we use Dettol. These are generally to be avoided because they don't remove the dirt. Dirt is only removed by disinfectant. The detergents. So what you need to use and clean, the important message is that the debris should not be there, which again is food for bacteria, which would multiply. Your disinfectant will kill, but the bacteria can become resistant to these disinfectants. They learn. They thrive in disinfectants if you use the same disinfectant. So the idea is, if you have 3 washes, all the 3 should be different. If I use only one particular product, chemical, the organism will learn to be thriving with that detergent, with that disinfectant. So in summary, the surface should be compatible for cleaning. Number 2, there should not be any crevices. Number 3, instead of disinfectant, use detergents which will remove the debris, and the surface will be clean and will not be harboring multiplying bacteria.
So detergent means what kind of, you mean liquid detergent?
Any detergent is all right, but ideally it should be a neutral detergent. How do you detect in your market? You buy 5, 6 detergents to your home. There is a pH strip. You dip it in and check the pH. It should not be neither acidic nor alkaline. It should be around 7. So it's easily you can do the test because the brands that are available in Bangalore may be different from what is available in Gujarat. So just test it and you will pick up. Most of the time it's a dishwashers. They are near neutral detergents.
Dr. Lane, sir, would you like to please?
Dr. Lane sir is not there. I think he
No,
is.
no,
No, no, just
he's joined, he's joined.
I have just joined,
Okay,
and
okay, sorry.
I was just listening, Ravindran sir, what he was talking about detergent. I think I agree with him. What he says is correct, and we can go for the further discussion.
So the consensus is to use detergents for cleaning OT, and surfaces should not have any crevices. It should be seamless. The edge of the wall should have coving. Epoxy flooring is preferred, or vitrified tiles is also preferred. That is the consensus. And you should not use any bactericidal agents to clean the theater, because there is a chance of development of resistance. Am I right, Dr. Ravindran?
You're absolutely right. But one
Yeah.
of the cleaning every day, what we do is we at the fag end of the day when we clean the OT and go, we do a bacillocid is the one we use it. Once a day we use it, but not repeatedly every time. And that also
Bacillocid for floor.
Yeah,
Is it used for floor? And
Floor.
what about tables? OT
Tables
tables
are
and
cleaned
trolleys?
by alcohol-based solutions, or as Dr. Ravindran said, benzyl chloride based. There are many products there, and that's the one is used to clean the tables, surfaces of the beds, trolleys, and all those things. There we use alcohol or BZK-based chemicals.
How do you clean the boils machine which is there in the OT?
The alcohol can be utilized. Any alcohol, 70% alcohol is the ideal, but not 100%, because there must be some moisture in it. So the contact time to disinfect a surface is about 5 minutes. If you rub with alcohol 100%, it evaporates immediately. So if there is a mixture of 30% water in alcohol, the 70% ethyl alcohol or propyl alcohol, it will stay on it for some time because of moisture. So that's what we should be using.
Paint can be used for even cylinders, oxygen cylinders or any tubes.
The oxygen cylinder should be cleaned with detergent first. There's a lot of soil in it. So before it comes to the operation theater, clean it up outside with what do you call it, detergents. And that is the only thing that cleans, removes dirt. Your alcohol will not remove the dust, neither your disinfectants.
Thank you, sir. So after cleaning the theater comes the question of fumigation or fogging.
Excuse me,
Dr.
can
Saurabh wants to say.
Yeah, I think one important thing is that because most of us have daily OTs, like those who are in the panel, but there are many surgeons who will do weekly OT or maybe twice in a week. It is very important to keep the OT clean even on days when there is no operations going, because I have seen that many surgeons, they will operate weekly and they will clean only once in a week, and that might lead to creation of colonies in the room. So very important for those who are operating not necessarily every day, they should clean even when there are no OT days.
Good point.
So even the walls and the floor, I mean, there is a recommendation that you first do the walls from top to bottom and then do the floor. So these are small points, but up to what height of the walls should we need to do? Just 4 feet or even higher?
The ceiling.
Sorry,
No,
up to
Up
even
to
the
ceiling.
ceiling. Yes.
Hi, Santosh.
So, Frederick, sir,
Hi, Nirmal. Yeah.
Hi, sorry to
wants
join
to-
late. Yeah.
Yeah.
Okay. I was listening to the discussion. Sorry, my audio didn't connect. One more thing I want is the usage of brooms in the theater. So this has to be strictly avoided anytime, whether it's terminal cleaning, last cleaning, last case cleaning, or first cleaning, how to avoid brooms. And second thing is up to the first, of course, the wall and then the floor. And disinfectant, of course, as Dr. Ravindra said, better not to use disinfectants, just wet mop or vacuum clean. And then surface disinfectant maybe once in a day, because the moment we open our theater and the crowd goes in, the surface gets disinfected. So no point in using high-end chemicals. We see many people using very high-end chemicals. So that actually leads to a lot of chemical resistance and overusage of chemicals.
so bacillocid once a day.
At the end of the session.
Yeah.
At the end of the.
Regarding
after
the
cleaning-
ceiling, if the ceiling is almost like 8 or 9 feet at least, so is the ceiling also to be cleaned every day?
No point in, because the ceiling is not going to be infected, particularly
Correct.
if you're having a laminar airflow theater, no point in cleaning the surfaces and the ceiling on and off. So all you have to do is maintain the theater dry and see to that you clean the curvatures and crevices properly, and surface of the equipment we commonly use to, particularly at the body level.
Okay.
Ceiling is to be cleaned once.
Excuse
Yes,
me.
ma'am. Yes, ma'am.
Yes, ma'am.
Yeah, most of the points have been well made. I just wanted to add that if a theater, many people may have in the theater the split AC. And if they have that, all may not have modular ORs. So if a split AC is there once a week, we must climb the with the ladder and take out the filters, and top of the AC, everything should be clean. And even if there are pipes running or something is running on the high in the ceiling, it all needs to be cleaned from top, because slowly dust will settle on that. So we cannot ignore those areas, but it's once a week. It's not necessary to do every day. And about chemicals, you will meet representatives coming to you with large different types of chemicals. Bacillocid is something which was being used for a long time, and many people still use it. We have recently given up because it has formaldehyde and aldehyde. And the aldehydes are not really good to inhale throughout the day. It's almost like formaldehyde. And so we have shifted to what Dr. R.D. Ravindran mentioned, the ammonia, benzyl conium products now, and it is called D125. 1% is used. It does not have smell, and it's mixed with water, 1%, very mild it is, and it is eco-friendly. So people are shifting to eco-friendly products now and not use bacillocid.
The consensus bacillocid or D125?
No, Desbac, D125 is available as Desbac. That's a trade name.
Desbac.
Yeah, Desbac. So it's available easily, and it's cost effective also.
So Disbact is recommended over bacillocid.
Yeah, bacillocid, another point what Madam, just to add to Madam's point. So it is also corrosive. So if you use the higher concentration, it is corrosive, and the aldehyde vapor tend to settle in the inner parts of our equipment. So most of us use very costly electronic equipments. So if you see that any shortage issue or any circuit issues, you can see a thin layer of all these chemicals being deposited inside.
Yes,
So
oil deposit.
the manufacturers don't recommend this usage in the theater surgery. If at all you're going to use it, you have to push the equipment aside into a different room, and then only you have to use these chemicals.
Dr. Anaga, can I add just 1, 2, 3 points?
Yes.
One is, it was rightly discussed, this cleaning of the ceiling, walls and floor, that's called intensive cleaning. We will do it on a day when surgery is not there. Friday we don't operate, so we just do that. Entire staff are busy in it. They start with the ceiling, they go to the walls and come down. But everyday cleaning does not involve the walls, except if the bottom 1 foot. When they clean the floor, the bottom 1 foot is also cleaned along with it. It's considered a part of the floor. The coving and next 1 foot, it's easy for them to do it. The second is, as soon as you enter the OT in the first thing in the morning, note the smell of the OT. I mean, it should be fresh and nice, not with stink in it. Even if there's an iota of stink, that means there are colonies of bacteria or fungi growing somewhere else. The moment you come from outside to inside, just take a breath and see it. And that's, I've seen it, one of the very nice way of finding out your OT is clean or not. Okay, number 3, in addition to it being dry, it should be, the humidity has to be maintained at 40 to 50 round the clock. So there are various means of maintaining the humidity. The moment if it goes to 60s and 70, it promotes bacterial fungal growth wherever it is. So I've seen fungi on the below of the OT table. I've seen it myself in my eyes. And near the wash area where the moisture is high, you see the fungi growing there. All these, you don't smell it when you're inside the OT, when you put the AC on, especially if you're using the split AC. But when the AC is not there, it starts, emitting the odor, and you'll be able to feel it. Humidity maintenance in the operation theatre is very, very critical to minimize the growth of microbia. Next is, I think she rightly mentioned, Dr. Savitri rightly mentioned about the air conditioner. If you are using split air conditioners, it's very, very difficult.
So that we are taking as a separate question altogether. So right now we are just, so I think at the end of this, if there is a consensus, Dr. Saurabh, Dr. Meghur, now whether the walls need to be cleaned or not and what finally to be used.
They need to be cleaned, but not daily. That's what Dr. MSR has
we
said.
do, I think, weekly wall.
Acha, not every day.
Not every day.
We are using Basilosit. So maybe I'll consider changing from Basilosit to microl benzalkonium. So another thing, we were using Basilosit until now.
Yes.
So for everything now we will have to change. Even the OT tables also we are using this only D125 is recommended. In complete change from Basilosit to this, right?
Yeah, it is at present it is one of the safest chemical available compared to the old aldehydes.
Yes. Anaga, what we decided that to create no confusion and for clarity among people, let's use only one type. You know, you use bacillus somewhere and someday use this, someday use a D125. So change everything and we have completely changed to D125 everywhere. 1%.
Any specific dilution with D125?
1%, is 1%.
1%, yes, yes.
1%.
So the consensus is to use D125 instead of Basilosid, and to clean wall and ceiling once in a week. And every day you have to clean floor and lower 1/4 of the wall.
Operating table instrument.
One more thing, Santosh, we need not be so prescriptive because there is a wide variation in the number of cases we do. There are large surgical operation theater which are engaged from morning to evening. And there are theaters where they do only 2 or 3 cases per week. So we can't be really very prescriptive, but on a broader consensus, we have to ensure that the walls are cleaned as per the hospital policy and the floors are cleaned at least daily.
So
if you are not operating daily,
yes.
Yeah, even if you're not operating daily, it has to be frequently
cleaned daily.
Yeah.
Even if there is one case, I mean, the asepsis has to be maintained and cleaning has to be maintained, no? Whether it is 1 or 20. Okay.
So now let's go to next question.
Yeah.
Yes, after cleaning the... Yes, ma'am. Yeah.
I think it's very important because we do it differently. We clean the floor and the OR table after every patient. This many people don't do. I know that it was told that it is difficult, but we have never agreed to deviate from that, and we do that after every patient. All the dustbins are cleared. The floor is, there will be a housekeeping lady for each theater waiting there for the surgery to finish, and within a few minutes she'll just finish it.
Dr. Mahipal sir, you all have so many centers. Is there any protocol which is maintained in all your centers?
We are using Basilosid Extra, and we do the wall cleaning that's done on a Sunday. We don't take Juma off on Friday, as Ravindra said. So Sunday it is done, and we use Basilosid Extra. And this Dr. Savitri, I'm just wanting to ask one question. I'm pretty curious. Do you think that the incidence of, say, endophthalmitis or infections in LBP is lower than other institutions where they don't mop and clean and change everything after every patient is in and out? Because as far as LBP, the turnaround time is much higher than say an Arvind eye care system or other places. So I'm just wondering in case there is any establishment, because when I was in US, people won't even change their clothes. I think that's another question, and they would just put their shoe covers and from the parking with the shoe cover inside, because they said that the floor doesn't matter to that extent. So I'm just asking that I have seen that protocol in LP, but is there any evidence that over the years that you have done which slows down the procedures, whether it has increased or increased is not the word, reduced the incidence of endophthalmitis as compared to any other institution?
we have not compared that way, but when we publish and read the publications, our
Yes.
rates are almost similar to Arvind, and it may be slightly less than Arvind, but it's not zero. It cannot be zero, but we cannot be comparing unless somebody publishes. We cannot compare.
Okay.
People have to publish.
Okay.
So let's go
Let's
to
move
the
on
second
to the-
question. We had good discussion on cleaning of OT. Now we come to fumigation and fogging. So I need opinion from expert panel, Dr. R.D. Ravindran sir. Should we do it daily, weekly, monthly? What is the protocol which is followed at Arvind Eye Hospital?
Ravindra is giving more importance for cleaning. This is probably the most important thing we do. And we do the fumigation once in a week. So, and where we have split AC, those hospital theaters, we do maybe twice a week. So that's a protocol. And we use only formaldehyde. And we don't
Okay,
use
Potassium
formaldehyde.
permanganate and formaldehyde.
Yes.
Do you,
Yeah.
do you potassium permanganate and formaldehyde?
Yes, yeah. Because we feel that is the more potent. What we also take the advice from our oral lab colleagues. So whatever they use in their pharma industry, we also they feel that that's the best way to get rid of fungus in the OT. So
The fumes are carcinogenic. That is what is said. So how do you?
Yeah.
but I mean, it's kept closed and then it's aerated. We get into the theater maybe after 12 hours or 16 hours. It is done on a Sunday. And only on Monday morning we open. That's more than 12 hours time is there. And we also run the air conditioner to let out all the fumes. So before you enter the theater. So
Dr. Deepak Megur, your
Yeah.
thoughts on this?
and again the
Yes.
dose we use is very minimal compared to what is actually recommended for real fumigation. So when you want to really decontaminate the whole space for storage of food grains or some food particles, that the kind of dose we don't use. Probably we use 1/10 or even less than that. So
I haven't fumigated for last many years, frankly speaking. So we just our surface mopping and surface cleaning is what we have been doing. In our state, I think usually Dr. M.S. Ravindra is our guru. So he has been teaching us to avoid this for many years. Now we have been following the same thing. And the surface cleaning and mopping is given more importance. And in our hospital, we haven't done fuming for last many years. So, but touchwood, I think is working. And we do cultures regularly. We do get our culture reports monthly basis, and it works fine. So we haven't
What do
had
you use for surface cleaning?
Bacillocid.
He said.
Bacillocid.
So now are you
We'll
also
have
planning to
Lahane
change?
sir's opinion also regarding fumigation. Lahane sir, is he there?
Yes, sir, please unmute, sir.
So
Yes, I am there. I heard the R.D. Ravindran and also Meghud. So one is saying that he is doing fumigation with formaldehyde and the percentage used is very less. And other is saying that bacillocid. So what happens? Both things are correct. It is not that only the. Can you hear me?
Yes, sir.
Yes, sir. Yes, sir.
Yes.
So it is not only the bacillocid or it is not only the formaldehyde and potassium permanganate. See, it should be done weekly or like that. You can do it twice a week if there is a AC is some different or split AC. And formaldehyde, yes, it is always better to do it on Sunday, and then you can use this on Monday. So both type of fumigation is good. It is not that formaldehyde is compulsory or bacillocid is wrong. Nothing. Both are equal. And my another opinion is whenever we are giving the guidelines should be like that. They should not trouble us when something goes wrong. So whenever you are giving the guidelines, give general guidelines. And these general guidelines, what happens? The advocate, they come in the court and they say ki your guideline of MOS is this, AIOS is this, and this is this. We are no any body, regulatory body anywhere. We are not giving any, you can say, guideline to anywhere. We are just talking the science. And I think whenever we are writing the guidelines, don't write as a guideline. So right as a discussion happened in the seminar, and the seminar everybody's opinion was like this. So that will help us if there is anything goes wrong. Otherwise, the fumigation, the register is not there. Then why you have done bacillus seed? Why you have not done the formaldehyde? And you are wrong there. Because of that, it has happened. So many things they come crop up in the court. So both things are good. Now bacillus seed, they are saying it is more corrosive. Yes, it may be, but we are using bacillus seed maybe from 20 years. Formaldehyde we are using from 28 years. So nobody has got any cancer. But yes, it should frequency should be less. We are doing weekly. So that is what we do in JJ. But bacillus seed, yes, every day. Every day after the OT, we use bacillus seed and then close down the OT. And second day we use it.
So any opinion on fogging versus fumigation? Dr. Nirmal, you want to add something?
Yeah, I wanted to add,
Yes, madam. Yeah.
Yes,
we
ma'am.
also do not do formalin fumigation. We have not been doing it for a very long time. We were doing before with bacillocid, but now D125 is used for fogging once a week.
Okay, for fogging also.
25 is
Fogging
used for
also,
cleaning or fogging? For fogging also it is used.
Fogging also. Cleaning, we are always using that. And fogging is done once a week using the same agent and not formalin. We don't use formalin.
Concentration is different or 1%?
No, it's same. It is same. 1%.
So a recommendation even with OTs, with laminar OTs, modular OTs also, is there a recommendation to do fogging weekly once?
No.
Is it
No.
mandatory?
No, generally not advisable,
No,
because
it is not
in fact
advisable.
it will be deleterious for your HEPA filters, because all these gas particles will go and get filtered at the HEPA at the ceiling level, and it will affect the functioning of the HEPA filter. So it will reduce the life of the HEPA, and it will also affect the laminar airflow pattern. So it's not advisable.
Yeah, it's not advised for those. Yeah.
Even within Aravind, where we have laminar flow, especially in all new hospitals, we don't use the fumigation. So in other places where we don't have laminar flow, we just have a central air conditioning or a split air conditioner, then we use that there. Because these theaters, because of the humidity we have in our country and the overall hygiene condition, the dusty environment, the fungal growth in these theaters are real concern. So that's the reason why we use them. Yeah.
No, generally formaldehyde fumigation need to be avoided, because the concentration required to be having a bactericidal activity with formalin is very high. So it is actually, if you use at that concentration to have bactericidal effect, you have to use 800 ppm per cubic feet area. And particularly in major theaters, if you use this method, it takes anywhere between 8 to 12 hours for the gas effect to go. So most of us, we use overnight and then has to give minimum 12 hours for the gas effect to go. So before any people enter the theater. So you have to safeguard our people also. Most of the surgeons go after the theater people go enter and work for 3 or 4 hours. We have to take their health also into consideration.
So what solution do you recommend, sir?
No, if we using fumigation as a method, so we have to use non-formalin substances, and also ensure proper training to the people so that they don't enter
which one
into
do
the
you recommend, sir?
Substance.
Which
So
substance?
D125 or bacillocid. So there are a lot of newer aldehyde chemicals. It is costly, but over the long run, in the interest of our people and staff, better to use the newer chemicals rather than formalin.
Okay,
Anurag,
so-
can I add a point here?
Yes, sir.
Many people think that once we fumigate, we are safe. So that doesn't apply. Fumigation works only when you have cleaned the OT. Imagine there is a layer of dust there, or a layer of cream, ointment, whatever it is, or a layer of residual, anything chemical on the floor. If you fumigate it, under that layer, it will not be cleaning. Under that layer, the bacteria will continue to produce. Imagine there is a layer of cloth or fabric or something there. Under that, it doesn't work. So cleaning has to be done before fumigation. This is paramount importance, which you will have to remember.
Yes, definitely, sir. So that brings us to the next question. Like we all said that if there is a laminar airflow, then there is no need of fumigation. So does it become now essential that you have a laminar airflow, especially
It's a
from
must
NABH
to have
standards?
laminar airflow for
So
everybody.
this becomes the $1,000,000 question.
When Dr. Nirmal is coming for full NABH, he will not allow without so you have to decide if you want full NABH or
Okay.
not.
But
Scientifically,
scientifically and
MPS sir and
practically.
all others. See, basically, laminar airflow is a system to ease our infection methodology and also exposure to chemicals. Right? It's basically a cleaner and greener way of maintaining disinfection rather than depending on chemicals. So that is one aspect. And this engineering control of having laminar airflow catheter is one standard out of 365 standard objective elements. So all of us, even though aim for 100% in exams, we are also happy with 90%. So NABH doesn't focus only on this laminar airflow. There are other 364 elements to be precise in NABH eco standards. So we have to focus on those things first.
No, but I think laminar airflow is something that is now being put everywhere into practice, no?
Yeah, most of the larger institution has adopted this. I've seen this over the period of last 15 years, right from Shankar Netralaya, LV Prasad, I've been there to almost all the hospitals for accreditation visits. So they've adopted this and have really reaped the benefits over a period of time. Smaller institutions, yes, there is some resistance, but we've seen the many hospitals installing this and reducing their outflow over a period of time, and also have seen good return on investment if you look at that way. The second point is the standard wise and the accreditation system. We also don't focus only on the infrastructure part. We also see the process, how the process is done. If the infrastructure is little deficient, for example, they are using only a split AC, their process control has to be stringent. There has to be a surveillance and monitoring over their staff, and also a regular validation method for the autoclave, the CSSD areas, and the disinfection system. So you have to look at that way. So it's not only the laminar airflow system.
Yeah, it's not important just to have it. If it is not cleaned regularly, then it can in fact become a little more risky
definitely.
than having.
So it has to be monitored and maintained properly.
So if you have a laminar airflow, then definitely the consensus is it is not absolutely essential. Am I right?
Yes.
So if it is being used, then how frequently it needs to be cleaned? What is the recommendation and what is the evidence-based this thing on it, consensus on it?
Are you asking
I
if
think
you have it?
Yes, ma'am. Please answer, ma'am.
Yeah. So if you have the laminar flow system, there is something called particle count. The validation, the engineer who actually puts the HEPA filters and the laminar flow system, they have a method of finding out what is the particle count. And the particle count is fixed. Then only they know that their HEPA filter is working. So we recommend, and even NABH recommends, that once a year we should be checking our particle count in the ORs. And once the particle counts are okay, then you can you don't need to do any cleaning. But you will have to change the filters if the particle count goes bad or it goes beyond what is recommended. So there is no cleaning of HEPA filters, cannot be cleaned.
Yeah. The
be
HEPA
changed.
filter validation has to be there on a regular basis.
OT validation they provide for 6 months only. So after every 6 months, you have to get it validated again. And there are, though we cannot clean the HEPA filter, there are outer filters which are there, which are large bore filters, which catch basically the bigger particles. Yeah. So it's better that if you can clean it weekly or maybe 2 weeks, depending on how much time of OT you are running. So that will reduce the chances of HEPA filters getting blocked if you can clean those filters regularly.
These filters, the 5 and 10 filters are outside the OR. They
Yeah.
are not inside the ward, so they need to be cleaned every week. We
Yes.
actually take out the filters, wash them, dry them, and then put them back. They are on the terrace or they are somewhere outside. The HEPA filter, which is in the ward, that does not require cleaning.
Yeah. One more good addition would be to have a UV light in the AHU. So this actually adds to the this infection control system. So during the COVID time, it was very useful for many theaters.
No, but what about
Going to
UV
ask
light
that
in the
question.
OT? When
UV light in the OT is generally not advisable, sir, because again, the exposure norms under the OSHA control. So it's an occupational hazard.
no,
So
that's
again,
that's put on when there's nobody in the OT. I'm not saying when because otherwise you get bad keratitis if you have the UV light on when you are there. But at least now you have those covered ones. These are the air filters along with the UV light. So it pulls up the air, also goes the UV light, and that doesn't cause any exposure or anything like that. So that is what we use in our LASIK OTs. At least that's the only thing, because we don't use
in a controlled environment, it is fine. You have to regulate and control the environment where you use the UV light, and also ensure that the other equipments are covered, because over a period of time, exposure to UV light leads to discoloration as well as surface damage of these equipments.
Is UVB light, right? Is
One,
it UVB light?
Yes, I
UVB.
think it's UVB light only. I can send you that. Basically, that comes in a plastic. It's covered all over, and there's a fan at the bottom. It's both an air filter and a UV light, so the air goes through it, and it sucks it and causes the air filtration. It's an air purifier plus a UV light inside.
just
UV
one caution for those who use these kind of air sterilizers, because there are many things in the market which are air sterilizers. They have to be cleaned frequently, otherwise they themselves become source of infection. I have seen it in couple of OTs where I had to go to find what was the fault, and they had these air sterilizers inside, and inside they had not cleaned at all, so they were the source for the spores. So when you are using use and clean regularly, even these dehumidifiers you have to regularly clean.
Correct.
Okay, all air filtration systems have to be cleaned properly. So whether it's split AC or the dehumidifiers,
Yes, so even the
or the
split
new
AC,
air
how
sterilizer.
frequently, sir? Once every week?
Again, depends on the number of the load in the theater. See, there are theaters we use only once in a week or once in 2 days, and there are theaters where they use 40 to 50 cases in a day. So you cannot give a prescription for all as a common prescription. So you have to depend on the load, the number of people in the theater, the size of the theater, and how frequently there is a turnover. So like LVP gives a gap of say 20 minutes. So there is adequate time in between the cases for the laminar airflow system to work and change the air. So there is enough time between the air exchanges.
So for an average of 3 to 5 in a day, for example, for a general routine single common practitioner, so how frequently will it be recommended?
No, if you're doing it daily disinfection at the end of the day, maybe once in a week would
be fine. So even the split AC, the filters
has to be cleaned regularly, once in a week.
Regularly.
So if there is no HEPA filter or AHU, then if a person is using just the split AC, then is this air filter actually of any use?
Yeah, air filters are used. Now there are even HEPA filters for split ACs. Okay, but these are all jugads which came during the COVID time. But it's very difficult to validate them. The problem is in the validation and calibration. Okay, so you can use for your mental health, but it's not going to help you unless it is properly validated and calibrated.
Correct. And regarding the use of dehumidifiers in LASIK OT, definitely we are using, but in cataract OT also, is it recommended?
No, it depends on the area, because in a high humid condition like Chennai city, definitely you would need. But in a white country, it's very difficult to give any prescription for this usage of dehumidifier. So you have to ask the air HVAC engineers what is the humidification requirement for that particular area and that particular theater. Accordingly, you have to install either a dehumidifier or humidifier.
I think, can I
Okay.
add? Yeah.
Yes.
So as Dr. M.S. Ravindra sir told initially that one has to have a humidity meter inside the OT that should decide whether you would want to use a dehumidifier or not. So if you have the goal is to maintain your humidity between 40 and less than 50, between 40 to 50. So people even who don't have this laminar airflow, if you can have this humidity meter, you can always gauge and then you can decide. So my place, it's a dry place, it's a non-coastal area. But I'm surprised that many times, even after having an AHU inside, the humidity goes up. In fact, even with the AHU on, the humidity goes in. So there is something like, you cannot take it for granted that non-coastal areas, the humidity will not build up. So every OT should have this measuring instrument and then you can decide. And I definitely feel dehumidifier is required in most OTs, if not in all.
Yeah, you can install the dehumidifier within the AHU system also. You need to ask the help of your engineer. So they will help in giving a heating system
Yes,
within
coil,
your
yeah.
AHU.
Yeah, actually they did, sir. Actually, the first time we
Okay.
did, then we had to install a heating coil inside.
Yeah.
And whenever the humidity goes in, we are on the heating coil. So
Yes.
even these laminar flow people are learning along with us.
Yeah.
They
No,
are.
in
Yeah, of course.
fact, if my
Post
laminar,
COVID.
we have laminar flow OT since 2004. I think ours was probably one of the first ophthalmic OT to have laminar flow. And because one of my relative is in pharma industry who does HVAC, so he had installed this heater coil at that time. So when I purchased a new laminar airflow for new OT, we found the same problem as Deepak found, that suddenly humidity was rising and he didn't know what was happening. And then we realized about the heater coil. But another way, because heater coil, they will take a lot of electricity. So another way, as Frederick sir was saying, you can keep a dehumidifier inside the OT and you can monitor and check. And coastal areas, I think those who are having OTs in coastal area, just keep the dehumidifier on all 24 hours. Not just in OT, but even in the diagnostic rooms, because humidity, breaks down a lot of electronic equipments in the OT as well as in the diagnostic. So I think it's a very good tool to have in your OPD as well as OT, particularly in coastal areas and rainy season.
Yeah, the first 6 months to 9 months, you have to, whenever you install a laminar airflow system, first 6 to 9 months, it has to be properly calibrated throughout the 3 seasons. So generally in our country, it's only 2 seasons, hot, hotter, hottest, right? So accordingly, you have to calibrate your laminar airflow system in these 3 seasons, and you'll hit the exact zone with the help of your HVAC engineer. We need to work with him to find when our the lenses are not fogging, and also monitor the humidity systems.
A simple thing like humidity also is so important for everybody.
It is a science by itself. Unfortunately, we don't understand the science behind this usage of laminar airflow system.
But one thing I would like to add, that laminar flow OT has not been proven to reduce the infection rate, because there are many studies. There is no role of laminar flow OT to reduce the infection. So for those practitioners who don't have it, I think doesn't matter. And most of the times, if you have a long list, it helps because it keeps on reducing the CO2 load inside the OT. That keeps because the fresh air is being added. I think for having long hours in OT, laminar airflow is very useful. But those who have just 2-3 cases, just 2 hours of working in the OT, I think laminar flow is not really essential. And in fact, NABH also should look into these things while, allowing, because even in orthopedic surgeries, joint replacement, neurosurgeries, there are studies, big studies showing that there is absolutely no effect of laminar airflow in infection control.
Good point. So I think number of people less. Sorry, sir. Yeah.
Just whatever Dr. Saurabh said, we have OTs which have got split AC, we have central air conditioning without HEPA filter, central air conditioning with HEPA, we have laminar. All of them have got a similar infection rate in our hospital, in our system. So, and again, recently there is a guideline from WHO saying that this is not necessary. As he said, for the joint replacement surgery also,
Yeah.
You don't need laminar flow is one of the recent recommendation from WHO Action Group.
Let's move on to the next question.
The end of the
Anaga, just one warning about dehumidifiers. Of course, now dehumidifiers have got very good electronics. Earlier ones, they weren't having. See, you should set the humidity not to go, especially when you're running round the clock, not to go below 40, because if the humidity drops to 30 and 20s, then there is a electric, what do you call, the fire can happen. You put on the switch and suddenly electricity travels across, because a dry air is very highly conductive for electricity. So especially in LASIK OTs, I know personally that there are 3 OTs, 3 LASIK machines got burnt and they lost the entire machine. Fire accidents can occur if the humidity is too low.
Good input, sir. Excellent input. Yeah. So we have already discussed about cleaning, sterilization, fogging, air handling units. Now comes the important question of how frequently we should do swab culture testing of OT, and which part of OT ideally should be tested. Can I have Dr. Ravindran?
Yeah, I think I'll say about this.
Yes, madam. Yeah. Go ahead. Yeah.
If I often teach this aspect of the OR, if you read any microbiology or any infection book, you will find that regular microbiological testing of the OR is not required. It says not required. And I agree with that, but we don't follow that. I'll give you the reason why we don't follow also. I agree because by testing, doing microbiology testing, you are actually not cleaning the OR. You are only testing whether you have cleaned or not. Now, why not we emphasize on cleaning and emphasize on protocols which will be definitely done and they will never be deviated rather than testing.
Agreed, madam. But how frequently we should test? Whatever we are doing, whether it is correct or not.
Now, if it is not mentioned in the books that they should be tested, it will never be mentioned how frequently, isn't it? So what we all do it arbitrarily. And we have decided to do once a month, and we take swabs also we take on our own. We take from the operating table, microscope handle, instrument, trolley, and I have included if there is a duct, you will have ducts. So that is mainly to see that that area has been cleaned, and it is not really scientific why you have to take a swab from there. We never take from the floor, from the wall, and from other areas. We only take from the OR table, microscope handle, instrument trolley, and so that is also what is decided by us. It is not written anywhere.
Can I have opinion of Dr. Ravindran, sir?
I also agree with Dr. Savitri. I think that's the reason we also do it just once a month. We use a settle plate method, and we also take swabs from the operating room trolley and the microscope. And we also use the settle plate, culture plate. We place them in the AHU also. We run the air conditioner, and we also place them in the AHU. So just to make sure that the AHUs are also free of any contamination. And usually what we really look for is is there any fungal growth? On and off, at least once in a while in one theater, in one corner, we may see a fungal growth. And those theaters, we again re-clean them and do it after 2 or 3 days. So otherwise we don't repeat it. It's all happens only once a month.
Yeah. Just to add a point, Santosh, in many Clinical Establishment Act in many states, they've added this line that every month the swab has to be taken, report submitted to the registry or the Joint Director of Health Services. So if there is such a note in the Clinical Establishment Act, we have to follow that. So at least once a month we need to take this. So otherwise,
anybody else?
Dr. Lahane sir's opinion, please. Lahane sir is there?
Okay. Can you hear me?
Yes,
Can you hear me?
Yes.
See, NPCB has given the guidelines that the air settle plate should be taken once a monthly. and also the swab of the operation theater. That is a you can say table, microscope, trolley, floor, and the wall. Swab should be taken monthly, and air shuttle plate, and the record of that should be maintained. It is there in the guidelines of the National Program of Control of Blindness. So that we'll have to follow. That may be government or that may be private. Because anything goes wrong, then it is asked by the inquiry committee that was it done and is the record is there. So monthly.
Is the water also tested, sir?
Yeah.
No. Water monthly. Water. See, you'll have to clean the your this one tank monthly, and you will have to give the, you can say, the water purified or not purified 3 monthly.
So is the water culture you mean, right? Water culture?
Yeah,
No,
just
culture
one.
is not. Yes.
Is
Yeah.
it for potability or water culture? No?
No,
No,
I just,
water
No.
TDS meter. The
No,
TDS
water is not
water has to
culture.
be
Water
maintained.
they
Need not do a
see
culture.
the pure water. It is not culture.
So your voice is cracking. I'm not able to
can
hear.
you hear me?
Yes,
We
madam.
can
Yeah.
hear you, ma'am.
Can you hear
Yes,
me?
ma'am. Yes, ma'am.
Yes, ma'am.
Yeah. I just wanted to add that we are doing these tests mainly for medico-legal reason, as Dr. Lahani also said. If something happens, then they ask whether you have been doing it or not for much of scientific reason. And the water also, actually, when you test the water right from the coming into the tap, it will always have Pseudomonas. So we just wanted to check whether any difference it makes if you have the AquaGuard or if you have the RO water. So to see a difference, you will always have Pseudomonas when you take the water from tap water and test for culture. So we do culture, and it is mainly to again make the staff know that they are being tested and they must keep everything clean. So it is mainly for again a reason to keep the staff on toes rather than scientific reasons.
So, ma'am, if there is a Pseudomonas positive, then
no, so Pseudomonas should not be there in the scrub water. Scrub water should not have Pseudomonas, but tap water will always have. So you have to have systems. There are different systems. We used to have AquaGuard before. Now we have RO, and RO always comes sterile. We don't get, because there is a 0.2 micron filter also fitted there. And some people use boiled water. Again, you will not have Pseudomonas. So you have to remove the Pseudomonas from the tap water.
So you mean to say the scrubbing should be done with RO water only?
Yes, if RO is available.
So is this followed everywhere? The same.
The recommendation for scrubbing is only drinking water standards.
Yeah.
So
No, but RO water
need not be RO water. It is a drinking water standard. So it can be a boiled, potable water.
Boiled water can be.
Boiled and cooled water can be used. But using it directly from the tap is not advisable. But as Dr. Savitri mentioned, we also check the tap water for E. coli and Pseudomonas. And we also make sure that it is not there, the tap water. And if it is there, we probably do some kind of a chlorination of the main tank.
So that means water culture you are doing once every month.
Once a month we do it.
Yeah, along with the other cultures, we do the water culture.
Water and air also.
Dr.
By
Megho,
keeping petri dish open.
also the same thing that is followed at your place? Please unmute. Please unmute.
Yeah, we are doing the water culture along with all the swabs. It is all sent along with the same thing every month once. So we are using we are not sending the general water, the water which you use for scrubbing, that we send it for culture.
So what you are using for scrubbing?
We are using Kent RO, whatever Kent RO, we had put it there inside our OT. And the last cleaning is always done with a boiled water. So boiled and cooled water.
How do you store that boiled water?
It's in an electric kettle which comes. So directly we plug it and it is there inside the electric kettle, and then we are using it. The last scrub is because with that boiled and cooled water.
Ravindra sir, MS Ravindra sir.
The water does not have to be sterile. This is the hand wash need not be sterile because you can never sterilize your hands. Even you can scrub it, whatever you do it, after another half an hour, the bacteria from your pores will come outside and enjoy the surface. This thing. What is needed is the clean water. Potable water is very well defined. In our system, we have the borewell water, which has TDS of 500, 600 like that. So that goes through the sand filter, which removes all the organic matter. Then it goes to the charcoal filter. There are readily available. We don't have to invent a wheel on that. And the last one is a demineralizer. So the output at the end will be around 50 to 70 TDS, and it will not have any organic particles. At the fag end of it, there is a filter which filters in case there is any accumulation of particles in the pipeline. This filter will take care of it.
So simply put, either an RO or an AquaGuard needs to be used. And boiled water at the end, Dr. Saurabh?
Yeah. And now RO is available.
I think one point I wanted to make, one point I wanted to make is that in OT scrubbing, the most important step is how you wear your gloves. So if you use proper no contact technique of wearing gloves, actually the scrubbing doesn't matter, because as most of you are saying, we are using at the end water to wash your hands, and then you are wearing gloves, and this water is not sterile water. This is basically a potable water, whatever, whether it is RO or anything. So most important thing we have to teach either our fellows or is how to wear the gloves with non-contact technique perfectly. I think that is the most essential step. In US, I have seen people don't scrub also. They just use sterilium, or there are, I think, waterless system of hand rub, and then they wear the gloves and do surgeries. I think that is very logical, because ultimately the gloves have to be sterile. Hands cannot be sterile.
No, but don't we
gloves
use
is important.
sterilium in India also after doing the wash and drying up?
We also
I always use a sterilium before I.
Most of us we use sterilium.
I think that is the most important
final,
part of
final thing that is touching your hands is the sterilium and not the
Sterilium.
last rinse that you're doing.
correct.
And
Yes.
I would say that we know that the hands cannot become sterile. That is no reason why we should not take care for the quality of the water. You can't be adding the organisms on the hand. It has to be reduced as much as possible. So we cannot be careless about that.
So point taken actually. So care should be taken while putting on the gloves.
Yes.
And that is very important. And sterilium has to be used preferably before putting the gloves. So we go to the next question.
So that brings us to the question, do you scrub after every case and before every case? Suppose you have a list of 10 cases, Dr. Maipal sir. Suppose you have a list of 10 cases, do you scrub after every case, and what is the recommended protocol?
so I change gloves in between every case, and I use sterilium in between every case. And then I also put a dash of, on the gloves also, I actually take sterilium, and that's about it. Obviously, the drapes are no question. I don't wash between each case.
In LVP, they scrub after every case.
Yeah, I know that, but I personally don't do that. I change gloves and the drapes are changed, and I use sterilium in between every case.
Dr. Lahane sir, you have to add. Dr. Lahane sir?
Dr. Lahane sir?
I think he's okay.
I think in eye surgery, our surgical field is very limited. And at all, if we touch ocular surface gloves, in fact, that also we should avoid touching the ocular surface with gloves. Just use the instrument to touch. And what I do is I use double gloves. So I have a 7 and then 7.5 gloves. And I always change the upper glove in between the cases. So the sterilium related dryness or allergy of the hands is also avoided.
So you use moisturizer after every OT.
In Aravind as well, post-COVID, we have switched on to this double gloving technique, and we change the outer gloves for every case now. So,
but do you wash after every case?
No, we don't wash after every case. We just put the sterilium and then
change it.
So even if you have 20 cases, you can continue by just changing the gloves.
Ideally, after 3,
How
4
many
cases,
cases? Suppose you have a list of 20, then do you wash after every 5 or 10 or 20? Is there any?
So I think you have to take a nature's call if you have 20. So anyway, that's I think
Earlier, sir, you were saying something.
I
We
normally
should break after 10, 12 cases. So
Yeah.
50 cases.
We should take a break after 10 cases.
Usually, some people, most of us take after about 12, 15 cases and then we scrub again.
Yeah,
No.
scientifically, the organisms come back on the hand after some time. So that justifies actually either putting sterilium or scrubbing.
Okay.
No, but Dr. Aga, I just wanted this thing. Except for LVP, is there anybody else who is washing and scrubbing after every case?
I think
Yes,
Shankar
sir.
Nathan also, I think they do it for every
change
case,
it.
sir. I
Yes.
think LV Prasad and Shankar Nathan, only 2 places I am aware. But in most places, I haven't seen this, this after every case.
And those who have graduated and post-graduated, not graduated, post-graduated from there, do they still use that or they have left that?
What is done at RP center?
RP center doesn't. At least you can ask,
Gloves?
yeah, but when we were there, it did.
No, you used to change gloves only.
Yeah, we have done surgery with bare this thing,
Yeah,
and
those were long back.
there
That
were
was
no
long
gloves
back.
with that.
No. Hey, Dr. Ravindra, MS Ravindra, you want to add?
Yeah, I'm from Shankar Nethralaya and I used to, for years together, I used to scrub after every surgery. Then I realized that it didn't make any difference. Now, of course, we change gloves after every case and we use hand rub. The way that's described, we are all familiar. My grandson also knows how to hand rub his hands. We use that with alcohol.
But after how many cases you rewash again? Means you
Oh,
change the gown.
every 3 hours. Oh, gowns are changed for every case. I change the gown, gloves for every case. But scrubbing is, after 2, 3 hours, 3 hours, I would say.
So, okay. Gowns you're changing after every case.
Yes.
Dr.
Every
Mahipal,
case,
sir,
yeah.
you're changing the gown also?
No.
No. Okay. So let's move on to the next question regarding the zoning of the OT. Dr. Nirmal, sir, are you here? Can't see him.
It's dinner time.
I know.
Zoning
We
and
are
also the
already
structure of
overshooting the time, but
structure
Yeah,
of the
I'm
OT,
sure.
like walls and everything. What is ideal? Tiles are ideal or epoxy paint is ideal?
No, zoning as per the regulatory norms, it is part of the regulatory norms. It's ideal to have 4 zones. The area where you operate, that is the sterile zone, then the semi-sterile zone, the administrative zone, and the disposal corridor. In single OT, it's very difficult to maintain this zoning. So there, the mixing of dirty and unclean, clean and unclean areas have to be avoided. So this is generally the principle. As for the walls, it has to be smooth. It has to be cold for easy cleaning, and any hard surface will do. So if at all you're using a granite or things, ensure that it is moisture-free granite and not the
Porous.
hard granite. So now many theaters, they're using the carbonite, which is good enough. Or you can go for the newer things like PVC or epoxy walls. Flooring, again, epoxy or vinyl flooring. You can use marble. Again, if at all going to use marble, hard granite marble, you have to ensure that there is no moisture.
Is epoxy better than granite?
Not necessarily. Granite is, in many theaters, we are seeing granite being well maintained, particularly the joints. So if it is a large granite and less joints, it is easy to maintain. Right, epoxy, there's one point you can't use the trolleys, so it can get damaged. With regular wear and tear will be there. So every 5 or 6 years, you need to change the epoxy because of the wear and tear. So PVC is slightly more sturdier than epoxy. So even with trolleys, regular usage of this material, the movement of microscopes of trolley doesn't get damaged much.
Because in pharma industries, it is usually epoxy paint which is used.
Yeah, in
manufacturing.
pharma industry, there's not much of movement of equipments like microscopes or the trolleys. Okay, there it is more of fixed thing. But in our theaters, we have stretchers, trolleys, and the microscope being moved. So the surface gets damaged. So once it gets damaged, while cleaning, there is seepage of water, and during the wet mopping, the seepage into that. So the area of damage gets increased.
It's the ideal size of OT, and can you have 2 tables in the OT?
Okay, ideal size as per the ASHRAE standards and the National Building Code for any critical area where the operation theatre is classified as critical area, it is 20 by 20. So, but again, it can vary. There are procedure rooms, so which can be around 160 square feet also. So how you name it? What is the scope of services? What are the type of surgeries you're going to do? Number of people inside the theater, the type of equipments you're going to use inside theater, all this will, so these kind of calculation is needed to know the size of the theater. So you can't be really very prescriptive about the theater size.
No, but his question was, can you put 2 tables?
2 tables can be put.
Yeah, if you're not operating simultaneously, yes, you can.
When there are 2 tables, how many people are allowed usually, and what size of theater it should be?
See, the standard requirement is about for a patient being operated, 7 to 8 is the standard size of the team, surgical team. And the size, so of course, a theater table comes in 2.5 by 6.5 feet. And surrounding area, there has to be at least 2 feet clear zone for people to move. The machines, the support machinery system should be there. So ideally, for a single table, you need at least 160 square feet. So if you are using 2 tables, slightly larger, there have to be enough space for men, material, and resources to reach to the head end where we operate.
But it should not be simultaneously used for surgery.
Yes, patient safety reasons, it's not ideal to use simultaneous surgery.
Safety reasons.
Both.
Any specific?
Because when 2 patients are being operated simultaneously, there can be mix of lenses, consumables, and also there is risk of cross contaminations.
Yeah. But at least it can be prepared, at least clean, draped, and then you can shift to the next.
Patient can be kept ready at the second table.
But Dr.
Yeah.
Nirmal, this
but
patient
limit the number of people.
No, but if you are cleaning and draping the other patient, is that allowed as per NABS? That's like basically, obviously, there'll be people who will be cleaning or draping, so that's to save time.
Yeah, sir. Not simultaneously, sir. At least we have not seen that during the assessment days.
No,
but
that's
of course
fine.
It happens on the other days.
But sir, the reason for having 2 tables is to do things fast. So naturally, when other table is there, it will be prepared for the next case to happen. There will be people for both the tables. I don't believe that it will be kept empty until the case is over. So at LVP, we don't do this at all. And we want less people as possible in the OR. So we don't have any tables.
As less people and as less movement inside the theater when a surgery is being carried out.
So we have only 1 table.
So the fastest person I have seen do surgery is to actually remove the trolley and push in a new trolley. So that's Dr. Thin in Jalandhar.
Yes.
What he does is that he's being
everything happens outside the theater. The patient is wheeled in.
But his theater is very big. He actually prepares within the theater. I think it will be about 600 square feet or 500 square feet. And on a separate trolley, the patient is getting prepared far away from the other one. And the moment the surgery is done, they pull the trolley and they push the other trolley in. That's about it. So that's the fastest system I have seen anywhere. And then he uses separate phaco probe and a separate IA. So he has 2 machines simultaneously tuned so that he doesn't even have to change the IA handpiece. So there are 2 machines for the same person, and one does the phaco part and the other does the IA. So you just pick it up and change that. So that's the fastest system I have seen, less than 4 or 5 minutes getting a patient in and out.
How many?
Sorry? Sorry?
Turnover is how many in an hour in Jalandhar?
I think obviously 4 or 5 minutes, so 12 to 15 patients. He had, yeah, in an hour.
They have seen in many places, sir. They use 2 trolleys, which is prepared in the adjacent theater or clean area, and then once the patient is shifted, it is instantly it is there within few minutes inside the theater. And so there are theaters where the patient is wheeled in there, so that it is prepared outside the theater area, and the patient is wheeled in with the eye mask and everything. So there are a lot of variations in the way we reduce the turnover time.
Yeah, thank you, sir. It's already 9:30 and we have just about completed only the OR related part, and the patient related questions are still pending.
Quickly, yeah.
We can just take it quickly.
Yes.
So the first question is, what are the mandatory investigations that are required as a protocol before a cataract surgery? Dr. Deepak Meghur, would you like to comment on?
I think the regular blood investigations, blood sugar and HIV, HbA1c, that we do for almost all cases.
Essential? Yeah.
Yeah, I don't know. We do it. Yeah, we do it for every case. And of course, if it's a systemic illness, then we always have a physician checkup and get the fitness certificate. And these are things which we do routinely as far as systemic illness is concerned.
Because a lot of doctors may not be taking physician fitness before surgery. So is that recommended?
No, if the patient has a systemic condition like hypertension, diabetes, something, then always we insist. But totally healthy patient.
He may not have, but may be undiagnosed. So,
yeah, but when we record, no, when we test him, we do test for blood pressure. We do test for his blood tests.
ECG is done for every patient?
ECG, we don't do it, but if there any medical condition, we just advise him to get it done.
We do ECG for every patient above 50 years.
Above 50.
Nirmal, I just wanted to ask you a question. Yesterday, you had said that can't a patient deny getting an HIV done? It's, I think it's whatever are the, or whatever are there, there are some rules that you can't ask a patient to get an HIV done without an explicit consent.
Yes, sir. So he has a right to refuse. So, but you have to document that in the case record that he has refused, and then we have to take the risk and use the standard precautions and carry out the procedure.
We can't do without consent also.
Yeah, that's what I'm saying. You have to actually take a positive consent to do an HIV test. That's what, when it came, that's what the rules were. So I don't know.
We learned that from NABH.
Yeah.
Verbal consent is valid? Is verbal consent valid?
No.
No, it has to be documented, Santosh.
Document, written consent.
Oh, okay.
We never take a consent. That's one of the problem. They can come around and say, HIV.
Yeah.
What about physician fitness and standby anesthetist? Is it mandatory, standby anesthetist? What is the consensus on that?
There have been cases where doctors have been taken to court for this thing. So at least I have a anesthetist across all my centers. And they have said that you are not trained enough to do a resuscitation and things like that. So there have been consumer court decisions where the absence of anesthetist has led to doctors or ophthalmologists losing the cases. So at least I as a
recommended.
Well, I don't think it's possible in all cities of India. We don't have that many anesthetists also.
At least I am in 31 cities. I have it in all 31 cities.
Yeah, but there are many practitioners in tier 3 and even small cities. It's not possible. And we are basic MBBS also, so we have to get trained in basic life support. And I think better to have that rather than having standby for each and every case. Of course, high risk cases we should avoid without standby anesthetist.
But you try to to a court. They don't find anything.
That is right. But at least ophthalmologist should not say that standby anesthetist is must for each
I'm not
and every
saying
case.
it's a must, but as a precaution for any untoward incidents or whatever it is. I know there are people even for fluorescein angiography, they have a standby anesthetist because if there is a problem. You do have a crash card and things like that, but obviously there is something, the anesthetist is there in the hospital, so you do that. But at least in Center for Sight, we have an anesthetist every this thing, because there have been instances where you could lose a patient on the table.
So standby anesthetist is recommended, but not a mandatory.
But not mandatory, yes. What are the preoperative protocols regarding the antibiotic, systemic or topical NSAIDs to be used?
3 days before, 4 times a day. NSAIDs, you can start a day or two earlier, but definitely as soon as the dilatation is ended, I put NSAID drops 3 times at 10 minutes interval. What else? Post-op, I give for about 5 to 7 days antibiotics. And for CME, specifically, we give Nepafenac for 3 weeks on diabetics for sure, and other patients who would require.
Anybody else having a different protocol?
I think pre-op antibiotics, 1 day, 2 days, or even 1 hour prior to the surgery, all have shown similar effects, having the same concentration in the cornea and aqueous. So it's not mandatory, but if patient can use a day prior or as 2 days prior, that's fine. But by studies, it's not mandatory for 2 days. Even 1 hour prior to the surgery, you can start the antibiotic.
But povidone iodine is the most important thing.
Yeah, that is the only proven thing.
I think studies
Enough
have
contact time.
Sorry?
Enough
shown
contact
that
time.
even no antibiotic is really required. Don't use mostly. No pre-operative antibiotics.
No
For
preoperative
or
antibiotics
against
in LV Prasad.
Sorry?
Savitri, madam.
Are there any evidence-based protocols for or against the use of antibiotics, madam? Can't hear her, I think. Her connection is a little poor.
Yeah, general recommendation for antibiotic policies to avoid
Am I audible?
prophylactic antibiotics
ma'am.
unless it's proven to reduce the infection. So
Yeah, we don't
just
use
prior to surgery.
prophylactic antibiotic.
Povidone iodine drop prior to surgery is important.
Yeah, that is the only proven thing so far.
That is only one thing. And
Yes,
post-operatively, use of antibiotics and steroids.
Just for a week. So then we stop it. And
As short as possible.
Yeah. So we use antibiotics for a week, maybe at the maximum 10 days, and steroids for about 6 weeks. And we also taper, as the patient is tapering the steroids, we add NSAIDs for about 30 days. So,
is anybody using systemic antibiotics post-operatively?
I don't think it's recommended unless you have a risk assessment and there is a systemic risk.
So it is not recommended.
recommended, but yeah, if we have a patient who's got a PC rent with vitreous loss, vitrectomy we have done, then we use it for 3 days. We give it on the day of surgery, the next day, and 1 more day. So,
regarding post-op steroids, last 2-3 years, I have started stopping the steroids after 10 days suddenly, and just NSAIDs continue. And I have found that many times if you taper steroids over a long period, patient kind of develop a steroid dependence, and then they come back with kind of recurrent inflammation after you stop steroids. So this regimen has worked for me. Just 10 days of steroids and just stop, and start NSAIDs after 5th day, and then continue for 6 weeks.
Yeah, I also follow this
regimen. From day one. NSAIDs are not from day one.
Yeah, you can start, but 5th or 6th day.
Pre-operative, no? NSAIDs we are giving pre-operative, no?
Pre-operative.
Yeah,
No, they are talking about post-operative in all cases. So why would, except for maybe some odd cases where you get glaucoma and things like that, why NSAID has a significant, they're not cornea friendly to that extent. Why would you not use the time-tested steroids and just switch them over? Actually, there are papers also to say even if you don't give anything, versus some steroids versus NSAID, the kind of inflammation could be similar. But since you are giving either of the, is it only because you are having a lot of patients with steroid-induced glaucoma? Why have you switched over to NSAID? Because you are giving NSAID Because I give NSAID mainly to prevent CME and diabetics and things like that.
Yeah,
Okay, sir.
asking me. Okay, I give steroids, but only for 10 days.
No, but
And
why?
then it's-
Why would? Because then you are giving a month of NSAID. So if
Yeah.
you were to continue these steroids on tapering doses, you think that is worse than stopping it suddenly?
Yeah, tapering, I have found that when you taper over a long period of time, we get a few patients who come back with a kind of inflammation after stopping the steroids, which doesn't happen with these just 10 days of topical steroid. That has been my experience.
Okay.
Dr. Saurabh, you mentioned. So as we are tapering, we start the NSAIDs after the 4th week. So usually there is an overlap. The patient gets after 2 weeks of steroids, and after that, another 2 weeks of NSAIDs, and we have seen this recurrence of inflammation to be very, very low. So
NSAIDs for 6 weeks and steroids, taper it as early as possible.
Yeah.
Okay. And antibiotics for 5 to 7 days.
Yes.
And antibiotic and steroid should be separate. You should not use a
Separate,
combined
yes.
product. No combination product.
No combination.
we should avoid that combination.
In a case of epiphora, a patient who is complaining of epiphora who needs cataract, say 618, 624, what is the recommendation? I mean, apart from Roplas, which we know, Dr. Fredericks or Dr. MS Ravindra, sir?
No, generally we do Roplas positive or negative testing during the assessment. And in doubtful cases, we do syringing, not for all cases. And if
there is an NLD block.
Yeah, there is a NLD block, we have to do a DCR or DCT as per the demand, and then wait for at least 7 to 10 days for the wound to heal, and then we'll take it for surgery.
So what would be the interval between the DCR and the surgery or cataract surgery?
Generally 7 to 10 days.
Is that sufficient? 7 to 10 days?
10 days is enough?
Yeah, once the wound is healed, no point in waiting. No, it all depends on the severity of the cataract also and how the patient tolerates. We have to do a risk assessment and see. The risk
so if it's a fairly like 624,
then we can afford to wait for some more time.
I
So
normally
a mature cataract.
What is the recommended interval?
I don't know.
I don't think there is any prescription. Immature cataract and patient can wait. We can wait for a slightly longer time. But most of them, if they come with mature cataract and we accidentally discover there is an NLD block, we have to tackle that first and then do the surgery.
So if an endonasal, yes, sir.
Yeah, endonasal, yes, most of the time now we have converted to endonasal DCR. Again, the waiting period is 7 to 10 days. So once the internal wound heals, we can do.
Okay.
Once a block is cleared, we are free to do.
Okay.
Dr. MS Ravindra, sir, you want to add anything on this?
About NLD blocks?
Yes.
Yeah, I would certainly wait for a month's time, because generally tissue healing is fibrotic healing will take about a month's time anywhere in the body. So, but then if the patient is it's an emergency or lens-induced glaucoma or something, what I do is I do a temporary punctal block before I start the cataract surgery, because they may be harboring bacteria in the punctum. So we just cauterize, coagulate that and finish surgery, and then that will reopen after maybe a couple of months' time. Or you can put a punctal plug and carry on, so that there is no regurgitation of material for that in emergencies. Otherwise, I would like to wait for a month's time.
Punctal plug, Ravindra, normally has it is hollow from the center. A couple of these punctal plugs, you can have the regurgitation, so it's better to at least I wait for 4 weeks. And if you have to do it pretty early, then maybe do a conjunctival culture swab to see if you.
What about the other eye? If there is NLD block on one side, can you do cataract surgery in the other eye, or
Sure,
the risk is the same?
You can do.
You can do in the other. That's not a problem.
A special protocol for one-eyed patient, which you follow?
Culture sensitivity and take them first on the OT list.
You do conjunctival
For
For
yes,
all one-eyed
for
patients.
all one-eyed
culture.
patients?
yeah, all precious eyes I do a culture.
R.D. Ravindra sir, what is followed in Madurai?
We don't do unless we have a patient is got AP4 or undergone a DCT or a DCR. Those patients we do, otherwise we don't do it.
Achha. Deepak,
We
you
also
have
don't,
any?
we don't
No.
do culture. It's unlikely to yield any meaningful result.
So I don't do any culture
Yeah.
for any of these patients.
For one-eyed patient, do you do culture?
No. I
No, it
don't
has
do.
no role actually.
No,
I
no.
don't know.
But not doing culture, does it have any medico-legal implications?
No,
No.
we have
Yeah.
this risk assessment system. So when you assess the risk and then decide about the test to do or not to do. So as a doctor, you have this freedom. So you have to document this. So that is more important than actually doing the procedure, which may not yield much benefit.
Documentation is very vital actually in such cases.
Yeah.
And last question is, if do the patients also change completely before they enter the OT?
Yes, in our case, yes.
In our theater,
In,
yes.
R.D. Ravindra sir,
In all other theaters?
No.
What is the recommended this thing? Or they just wear a gown and a cap?
Gown, cap, and shoe cover.
What following?
cap and shoe cover on the top, right?
Which means they don't have any shoes anyway, no? They are not allowed to wear any shoes.
Shoe
anyway.
cover means
I mean, foot
leg
cover.
cover.
Foot
Leg
cover.
cover.
Yes,
Foot
yes.
cover. Yeah.
So basically for LASIK, they don't change, but for cataract and other surgeries, they change.
Are there any evidence-based recommendations, or these are definitely experiences, but is there anything, any guidelines mentioned anywhere?
No, the basic principle, Anaga. See, most of the debris and so it comes from our skin and the surfaces. So ideally, if we have a good surface which covers most of the skin, the debris that falls is limited. So that is one of the reason why we advocate less movement and less number of people in the theater also. So it's a basic principle to have a good covering for all theater personnel, including the patient.
Yeah,
And
just
are
to
these
say,
clothes
Dr.
autoclaved, or they are just washed?
Wow.
Even the surgeons, the scrubs, are they autoclaved or they are just washed?
Surgeon scrubs are
We use the
on-
disposable
Not the
gowns.
gowns, I'm saying just the scrubs.
No, not
Changing clothes. She means
The
changing
clothes.
clothes. Yeah.
Changing clothes. I think it's washed and dried.
Washed.
washed.
That
Yeah,
is
not
washed.
autoclaved.
Washed.
Not autoclaved.
R.D. Ravindran sir wanted to say something.
Yeah. During the COVID time, we also followed this protocol of having a gown for the patients, and we have not. And now we have stopped it after the COVID period. We haven't seen any difference in the incidence of endophthalmitis, either with the gown or without the gown. But we just follow the earlier practice of patients coming with their own dress. So we make sure that they come in a clean clothes. That's all. If they are not having it, probably then we put on a gown for them. So
If the clothes are not clean, then you put on the gown on the top of that.
yeah. Or normally we give them some clean dress. We have a theatre dress, so then we give them those.
And a cap?
Yeah, a cap and a foot cover. So.
So one question, Dr. Naga, I don't think just wanted to get from people, how many of you think you would or we can venture into bilateral simultaneous cataract surgeries?
We're coming to that only. What is the
You are?
medical legal
Sorry,
aspect of that? Sequential cataract on the same day.
Okay.
Yeah.
ISB.
Yeah.
Any
Yes.
promoters in India? I don't see too many, but yes, ICL, some people have started doing together.
See, with
And-
this recent episode of TAS, just imagine that patient landing into TAS in both eyes. I think that is the only thing.
There are 3-4 people I know who are doing cataracts also simultaneously. So where do we stand on that?
In fact, we had kept a debate in our conference, in our ophthalmological society conference way back 10 years ago. And for was Dr. Hardipurkar sir and against was Dr. Ramurthy. And it was decided that you do
What was the
sequential
result?
cataract after 1 week.
No, after 1 week, that you can do.
Yeah, I think most of us do that, Santosh.
Yeah.
We don't really
But
need a
he's
policy
asking
on that.
bilateral, simultaneous, sequential, he's asking.
No,
Yeah.
because
So
we are
it
doing
has to be
LASIK both eyes
risk-based.
together. Sorry,
Yeah.
we are doing LASIK
No,
both
it has
eyes
to be
together.
risk-based for.
No, what's the risk? People are even one-eyed patient is not considered a risk. No culture is done. Then what is the risk if both eyes are pretty good and there are no epi4 or no DCR, nothing at all? Then what is the risk? Young people coming in for ICLs. Obviously, there is one basic issue is that you can see the response on one eye and do TAS is one of the things, but outliers in an ICL, you're able to see a vault in the refractive correction and those kind of things. And
Refractive surprise also. What about refractive surprise?
Yeah, that's in a, but
Yeah.
see with the IOL masters and the Interion and all those things. So
Still there are chances of refractive surprise.
Oh, yeah, agreed, but I don't know. Dr. Ravindran, you have to start doing bilateral simultaneous.
Then we can have enough numbers.
Yeah.
We had a long discussion about this internally, and we kind of agreed upon delayed bilateral simultaneous, which is like after 3 days. So that's what we agreed upon.
Okay.
So if you have bilateral cases,
well, 3 days I do ICL next day. So that's about it. But Vardhaman, you're smiling.
No, sir. I also follow the same thing. I do the ICL the next day. Main thing is the vault, as you said, because we don't want to land up in very low or very high vaults. But what I wanted to know was if we are not doing simultaneous bilateral, but what is the minimum days gap that everybody would like to keep between the two eye surgery?
Yeah,
at least 3 days.
3 days.
3 days. But is there anybody, if, for example, the patient is flying out and patient wants the other eye to be done within 2 days, let's say, or next day?
Yeah.
Would you
These
do
are all
it? Or has anybody done
relative
it?
indications.
It depends. No? How the first eye has responded.
No, you see,
No, if
we need
first
to
eye is doing
have
very
certain
well, let's say.
absolute indications and relative indications.
So, but why is that a standard of care for LASIK? Bilateral simultaneous. The question is
Because
why?
it's an extraocular surgery.
It's not invasive.
Corneal surgery, why?
Extraocular.
Okay, then DALK is also as much as an extraocular surgery. Any corneal surgery, pterygium is extraocular, like whatever. I really don't know, because you can have infections following LASIK or anything, smile or anything. I don't know. But that's
Actually,
question.
The risk
Nobody
of
questioned.
endophthalmitis
refractive-
is not there, na, sir. I think that
I think
risk of
post-refractive,
endophthalmitis, which is sight threatening, is the one different between
The risk is there, no? Sight threatening.
intraocular and
Corneal ulcer can be sight threatening. That's not an
Yeah,
issue.
yeah.
Point
In
is
fact, I
that
think post-refractive corneal ulcers can be more difficult to manage
More
than
difficult
sometimes
to treat.
I
endophthalmitis.
agree. I
Yes.
agree.
Mm.
Yeah,
I don't know. Anyway.
maybe for some other day. So
And a real good discussion, very good inputs from the expert panel. And I would like to thank them for taking out time and discussing on this very important issue. And Dr. M.S. Ravindra sir, do you want to summarize?
yeah, in fact, everybody, I would
Everybody, yeah,
one
because
single one
one
line,
thing,
2 lines,
yeah.
your thoughts on this webinar.
This webinar and how to take forward this
forward,
important
yes.
issue. Yeah.
Dr. Santosh, before the final thoughts, order Swiggy or Zomato for all the panelists.
They're done.
Oh, ITC Borya.
One thing I would like to add is that we
So
don't
only
have
the
any-
president and secretary are here. So the treasurer has to be incorporated.
Treasurer is also here, sir.
Oh, okay.
Yeah.
Good.
we do not allow any visitors at all to walk into the operation theater unless he's an eye specialist. So even if he's a doctor, son of a patient, there are any number of video cameras available. They can watch from outside. That's something which we are very strict about. No visitors inside the OT. Number two is we don't walk into the OT, with straight dress at any point of time. Many OTs, they permit people, visitors, come inside the OT when the surgery is not happening, saying that anyway it will be cleaned at the end of the day. So whenever you want to get into the OT, you'll have to change the attire and get into it, because the street attire carry a lot of dust, and it's supposed to shred 1 million particles per hour or something like that. I've forgotten the count, but that's a huge number, scaring number.
Yeah.
So that's one. About patients, what we, from a long time we are practicing, instead of giving dress from our hospital, which many times doesn't fit to them, we encourage them to bring a pair of outer dress from home, wash them, iron them, put it in a clean, we give a cover to them, paper cover to them, or new one. They have to put, they very religiously manage, and they wear their own dress, and then they walk with the OT. So these are some things which we found very useful in our practice.
Ravindran, sir.
Any concluding remarks?
Concluding remarks. R.D. Ravindran.
Thanking you for organizing this. It's quite a learning experience for us also to see agreement and disagreement. And basically, I would like to say that I think we need to have our own evidence-based practice for this. There are no real, because a lot of the standards are based on general surgery. I think we need to find the standards for ophthalmology and practice it. So good to hear from Dr. Nirmal that we have 2 tables in the OT. So
Mahipal, sir.
Well, I think obviously it was started out of the recent episode on TAS. So we have discussed what we should be doing internally as regards this thing. I think that's a good learning because we need to set ourselves right. And let's hope that something comes out of the epidemic that we have, though. So that is something very important, that it's equally the self-introspection and good practices that the manufacturers have to do. And as I said yesterday, I think that's something that needs to be more rigorously enforced in India. But apart from that, congratulations. I think it's a good overall review of the OT practices, because as was said in the beginning by Dr. Anaga, that's our mandir, or that's our Gurdwara or Masjid. That's the area where you actually get people to get their vision back. And any best practices need to be followed there so that the outcomes are pretty good. Apart from the surgical skills, these are extraneous factors which we have to take care. And I think everyone should have benefited. I have definitely benefited a lot from what the experts have said. And as Dr. Ravindran said, I have had Dr. Nirmal saying that AHU is not mandatory and 2 voting tables can be put. So let's hope that the other invigilators also allow that. That's a great job, I think, done by MOS.
Thank you, sir.
I think a very great job was done, Anaga. Very impressive, Dr. Santosh, the way you have organized, and you have kept us all on our toes with your enthusiasm and spirit that I'm seeing is extremely great. And thank you for including me. I learned a lot, and this is one of my pet topics. Thank you so much.
Thank you.
Nirmal.
Yeah, as I reflect all their sentiments, thank you for organizing us on the
Any additional inputs which you would like?
No, additional inputs, I think you discussed enough. And I'm not giving anything as standard or anything. This is my experience of running a ophthalmic center, as well as using the standards to my advantage and learning. So 3 key areas. One is to have a written protocol for the staff to learn and follow. Second thing is training them. That is more important. So we get trained in many places. Same way we have to train our people. So that is what lacking in many hospitals. Third is monitoring them. So this is more important, the surveillance and monitoring of the staff. So we need to have some validation or some CCTV system to ensure that there is continuous monitoring. So if we can do that, we can reduce the incidence of TAS as well as endophthalmitis, and we can have a safe sleep.
Yeah, thank you. Deepak, Dr. Deepak.
Yeah, I think, as just like to tell that human error is the most important reason for all mishaps which happen in our OT, either TAS, endophthalmitis or something. So I think no amount of training to our staff is less. I think there's nothing like doing hyper or something about OT care. It is endless. And I think the most important personnel are our OT staff. The way we take care of them, the way we treat them, the way we make them our partners in taking care of our patients, that is the most important thing for us. That is they are our real heroes. And whatever we learn, unless and until those people don't follow, is of no use. So how we monitor them or coax them to follow all these guidelines which we have done, I think that is the most important thing. In matter of how many webinars we do, it's of no use unless and until our staff, it's ingrained in our staff. Ultimately, they are our heroes, or they turn out to be the
Actually, we are planning to have a webinar for staff next week.
Yeah, that is. Yeah,
that will
true.
be on 10th.
Keeping them motivated also is important. No, you just can't do them. We have to understand for everything and then teach them. That is the borderline. They can't learn on their own, or they're not motivated enough. We have to be motivated to motivate them.
No, unless the leadership is interested in all these things,
yes,
so the staff will not learn.
Absolutely.
So we have to show them the way and lead them the way.
Thank you.
Yeah. I think one of the things which I have seen is that many practitioners, when they start their practice, they are very keen that they will do everything themselves in the OPD for the patient. Like they will, check vision, do refraction themselves, even prescribe or dispense drugs. They will do the A scan themselves, everything, all diagnostics. But in the OT, they just delegate, sterilization procedure to someone and just trust. And I think that should not be there, because that is what I tell my fellows when they're going out, that CSSD is the most important part of your clinic. Because as Deepak also said, and Dr. Frederick said, that you have to continuously monitor. So you have to visit the CSSD very frequently. That is very important. And second thing is that for training of staff, I think what we did is that we made a lot of videos on actually how to clean, because many times we say things, but how it is actually done, it has to be taught to and we keep on getting new staff every time. So I have a lot of those videos available, and I have already uploaded on YouTube. I will upload on my channel also. And I think Vardhaman recently uploaded one of my video. I think video is the best way to teach our staff. And when you have more centers, it's even more useful. So I think those kind of continuous teaching is very important for the staff.
Training webinar we are planning actually. Vardhaman?
Yes. So I think as Dr. Bidesar said, because ultimately in these two webinars, we have gathered a lot of pearls. And ultimately, as Saurabh just said, because we are just delegating everything to our technicians, the most important thing is that the technicians have to be trained very well. So the next webinar from MOS is going to be especially only for technicians, and it is going to be in Hindi language, so that they understand. And it is going to be, basically targeted towards all the technicians all over India. So I think all the people who are also watching right now, all MOS members, AIS members, we would again ask you to watch out for the next webinar. This will be mainly for all your technicians, but also all ophthalmologists can also attend it. And the main plan will be to train them in the right way, so that we show them some right guideline and they can follow it. So that's the main thing. Yes.
Dr. Anaga, it was your brainchild, this webinar, these two things, and good hard work you have done. So over to you now.
Yeah, thank you so much, Dr. Santosh, for those kind words again, and for all the support. And thank you to each and every panelist for sharing all your lovely, valuable inputs. It's been great learning experience for all of us, and you have spent so much time from your busy schedule with us, guiding us. And then I hope this is going to benefit all the viewers and all the ophthalmologists. At least give them a guiding line, and then they can actually implement it in their day-to-day practices, and hope all this reduces incidences of TAS and endophthalmitis. So thank you once again to everyone. And I'm very happy that the new year has begun with the Safety First webinar. And thanks from the bottom of my heart to each one of you. Thank you.
Thank you.
Provoking webinar.
Thank you.
Thank you and good night.
Thank you, everybody.
Good night.
Thanks for joining. Thank you, sir. TTL, sir. Thanks.
Thank you.
Yeah.
Sir, thank you so much.
Thank you.
Thank you.
Thank you, everybody.
Okay,
It was a good learning experience and a thought-provoking webinar, actually.
Bye.
Thank you, Mahipal, sir, also.
Thank you, sir.